Look, it's fine. I think music is not working, but it's absolutely fine. We can do without it. We'll just give another 1 or 2 minutes for the last arrivals, and then we get to start. There's a little poll that of the little question or poll I've just set up. So whilst we wait for the last arrivals, you can take 1 or 2 minutes just to complete it. But we will be starting in soon. Good. You can still complete the poll. I'm just probably just start us. I will start us off. Otherwise, we can not fit in the time that we have. So, good morning, everyone. My name is Lisa Slavova. I'm the sales director at Stents Limited. We're honored that you all joined us today, and we're very grateful that you're here with us to hear what we have prepared for you. Thank you for making the time. I know some of you actually coming to us from different parts of the world, so it's not necessarily morning for some. So thank you. This webinar is part of a series of online webinars Stents is proud to be presenting. And I believe today is going to be a very good day for us all, because we gathered from all over the world to talk about endometriosis and how Stents can help cope with the pain associated with this disease. Until recently, there hadn't been a lot of talk about endometriosis, and information actually is very limited. According to the World Health Organization, endometriosis is a life-impacting pain, and in many countries, the general public and most frontline healthcare providers are not aware that distressing and life-altering pelvic pain is not normal. So this leads to normalization and stigmatization of symptoms and significant diagnosis delay. So if it's not yet on your radar, it needs to be. Endometriosis is one of the most common gynecologic disorders in the world and can cause debilitating pain to women. It is also one of the most misunderstood. So sadly, symptoms of this chronic disease can impact a woman's day-to-day activities, such as missing school or work. It can not only affect the woman with the disease, but also her interactions with her partners, friends, family. And there is a need for more research and awareness raising around the world to ensure effective prevention, early diagnosis, and improved management of the disease. At present, there is no known cure for endometriosis, unfortunately, and treatment is usually aimed at controlling the symptoms. In the medical world, generally, there are very few medicines, procedures, or therapies that can claim a 100% success rate, but Stents therapy, whilst it may not help every woman suffering endometriosis pain, it has helped and will continue to help many women. Therefore, enhanced awareness about this option of pain management may help reduce the long-term burden caused by the disease. And we hope today we can work together to raise awareness for this disease, educate others, and help change the way endometriosis is understood. So today we have prepared for you a few sessions focusing on data around this condition, and this will be presented by my colleague Madeleine Opet, our marketing manager. This presentation will be followed by an interesting insight on effectiveness of Stents in treating dysmenorrhea or primary endometriosis by our guest, Dr. Manisha Uttam-Soy, who has kindly accepted our invitation to participate in today's webinar. So thank you very much, Dr. Manisha. We have also prepared a demonstration or product training on our newly developed product Unicare, and this will be presented by my colleague Amna Shahzad, our UK sales manager, and followed by a chat about design features in the product presented by Hanwei Lim, our product manager. We also plan to have a Q&A session at the end of part 1. So after Dr. Manisha's presentation, we will open up, and we have also Professor Liviano joining us. You can see him on the screen right now, so he'll be able to answer some of the questions as well. So hopefully conversation will be very engaging. But also at the very end of the webinar, we again will open up a Q&A session. We will invite you all so we can see and chat to each other. You can ask your questions. If there is anything that you'd like our speakers to elaborate on, that will be your opportunity. So before we go further, I'd like to review some functionality of this Zoom webinar. Your active participation is important throughout the session. So right now you're all on mute, so it just helps to avoid the background noises that may distract our speakers. But throughout the presentation, you can enter your questions and comments in the question box or our chat. If you'd rather ask the question in person, you can do so. You can just raise your hand in the control panel. There is a button to do that. You're indicating your interest, and we will give you an opportunity to speak once that becomes available. So I just wanted to wish the very best to all our speakers. I hope you will enjoy and find insightful today's webinar. Good luck, Madeline. You're the first one to start us off.
Thank you, Lisa. Good morning, afternoon, or evening, ladies and gentlemen, depending on where from the world you're joining us today. As Lisa introduced, I will be discussing a few facts and figures and data around the condition of endometriosis. This topic is very, very close to my heart, as I'm a sufferer from endometriosis myself, have undergone 4 surgeries for the condition, and also fertility treatment as a result. So if we go through what is endometriosis, according to research conducted by the NHS, endometriosis is a condition where tissue similar to that of the womb starts to grow in other places, such as your ovaries or your fallopian tubes. Endometriosis can affect women of any age. It is a long-term chronic condition that significantly impacts the sufferers' lives. Endometriosis can be classified or is classified into 4 stages, either minimal, mild, moderate, or severe, based on the extent and location and depth of the endometriosis implants, as well as the presence and severity of scar tissue. There is currently no cure for endometriosis, but there are treatments that can help ease the symptoms. So what are those symptoms? As we mentioned, endometriosis has a huge impact on a woman's life and therefore can lead to depression and severe depression. You also experience significant pain in your lower back and stomach, restricting your ability to partake in normal activities. You can have pain during sexual intercourse, constipation, diarrhea, and as mentioned, difficulty in conceiving. Other symptoms include very heavy periods where women will use many tampons or pads and even bleed through their clothing. Research conducted on a panel of women logged these as the most prevalent symptoms that they would suffer from. So headaches, back pain, abdominal pain, and fatigue. Causes of endometriosis, as we've mentioned before, the exact cause of endometriosis is not known. Again, according to research conducted by the NHS, there can be a few factors that contribute to women suffering from this condition. One of those would be retrograde menstrual flow, and this is the most likely cause of endometriosis. And this is when tissue is shed during the period and it flows back up the tube into other areas of the body, such as the pelvis or fallopian tubes. There can be genetic factors that are attributed to women that suffer from endometriosis, as it does run in families. So who is affected? Asian women are more likely, 50% more likely, in fact, to be diagnosed with endometriosis, according to a study that was conducted in 2019. In the same study, Black, African, and Hispanic women were half as likely to be diagnosed as white women. 10% of women in the reproductive age, that's 190 million women worldwide, will be affected with endometriosis, and 1.5 million women in the UK suffer from the condition. Endometriosis can affect women of any age, background, and ethnic group, but it most commonly affects women in the reproductive ages of 25 and 35. However, women as young as 20 can suffer from endometriosis as well. So if we look at treatments, again, who is affected? So if we look at it from a geographical perspective, you can see on the map now we have high, medium, and low impact areas. So your low impact areas would be South America and Africa. Again, due to the facts that we've just discussed, it could be due to genes or a lack of testing, but your really high areas or demographic or geographical areas that are impacted would be Asia and Australia. Going on to the treatments and what treatment is right for you. When considering your treatment options, it is really important to consider a few facts, such as your age and whether you want to conceive in the future, as some of the treatments that aid with the symptoms of endometriosis can prevent you being able to conceive in the future. It is also really important to consider how long you have been suffering from your symptoms and how you feel about surgery. And it's really important to do your research. There are self-help groups on Facebook. There are self-help groups like Endometriosis UK. To join those, discuss treatment options with other sufferers and find out what would work best for you. Treatment options include pain medications such as ibuprofen or paracetamol. With taking any medication, there are always side effects, and side effects of taking ibuprofen or paracetamol can include headaches or dizziness and retention of water or swelling in the ankles. There's hormonal treatments or contraceptive pills, including the combined pill, the contraceptive patch, or intrauterine system, and medicines called gonadotropin-releasing hormone analogs. Again, these do have side effects that can include breast tenderness, nausea, bloating, or weight gain. It might not be the ideal treatment for young women. So again, that's where we say age is really important when considering what treatments and monitoring the side effects. Again, the combined or oral contraceptive pill, and then laparoscopic surgery. And that is where a surgeon will pass a thin tube through a small cut in your tummy, where they will be able to see the patches of endometriosis and then surgically be able to remove that. Lastly, in extreme cases, an operation will be performed to remove parts of the organs affected by endometriosis or the entire womb, known as a hysterectomy. Just some interesting facts on endometriosis. The prevalence of endometriosis in women with infertility can be as high as 50%. Endometriosis is the most common gynecological condition within the UK. It takes on average 8 years to be diagnosed with endometriosis from the start of your symptoms, and the cost to the UK economy alone is £8.2 billion a year. So when we look at endometriosis in the workplace, 40% of women with endometriosis report an impaired career growth, and 50% of women have a decreased ability to perform their work, missing on average about 20 working days due to symptoms related with endometriosis. So most women workers who have experienced period pain in some way or another have expressed that it has impacted their daily working lives, mainly by affecting their ability to perform their jobs or concentrate at work. It also physically affects how women are able to perform generally as they feel weaker. They often have to take short breaks away from their desks and call in sick or leave work early due to pain that they experience from period pain, dysmenorrhea, or endometriosis. There's not only a mental and physical health burden of the condition, there's also a huge economic burden. If you look at the total economic costs from endometriosis worldwide on the economy, I mean, that is a staggering figure, over $3 trillion. and worldwide on healthcare is just under 500 billion. Those are staggering figures for a condition that affects so many women. The cost of pain relief, as we mentioned before, it takes about 8 years to be diagnosed with the condition. So you have diagnostic costs as well as treatment costs. The average visit or consultation with a specialist is about £395 in the UK. Imagine how many consultations you're going to have in that 8-year period in order to be diagnosed with the condition. And then if you do need to take or partake in surgery, the average laparoscopic surgery, you're looking at about £4,800. So the figures are quite astounding. However, there are alternatives, which is what we're discussing today. Stents, and more importantly, the Unicare device. It is affordable. There's a once-off payment for the device, which you'll be able to keep for a lifetime. All you'll need to do is replace the leads and pads. It's instant pain relief. As I mentioned, I am a sufferer of endometriosis. I've used the Unicare device, and it really does work. It is a game changer. It has changed my life. There is no side effects. It is safe, effective, and drug-free. And it's really convenient to use. It's easy to assemble, easy to place the pads, turn on, and enjoy that safe, drug-free pain relief. I'll now be handing over to Dr. Manisha Utamsoy, who will be able to explain to us further the effects of Stents in the treatment of dysmenorrhea and pain.
Okay, thank you, Madi. I just wanted to say thank you on behalf of Stents Care team as well for presenting today. And yes, next speaker would be Dr. Manisha Utam, but you can see the PowerPoint presentation is coming up shortly. We don't have any more. Yeah, good. All coming up.
Yeah. Thank you, Lisa, and thanks to your team for inviting me here. Good morning, good afternoon to all of you. So I'm going to share my ideas and my views about this topic of dysmenorrhea. So topic of my presentation is effectiveness of transcutaneous electrical stimulation to cope up with menstrual pain or dysmenorrhea. So first of all, definition is dysmenorrhea is painful menstrual cramps that begin few hours before or with the onset of bleeding and may persist for hours or days also. And the current scenario from a study of 2015 suggested that this dysmenorrhea is one of the most common gynecological complaints among adolescent girls and adult females. Now, dysmenorrhea is further categorized into two types. It can be primary dysmenorrhea or secondary dysmenorrhea. This primary dysmenorrhea is usually common among young adolescent girls, and it occurs after menarche, just after menarche, after 6 to 12 months, and it is not accompanied any gynecological disease or pathology. While secondary dysmenorrhea always accompanies some gynecological pathologies like endometriosis, pelvic inflammatory disease, ovarian cyst, and it also occur at any time period between menarche to menopause, and it is less common as compared to primary dysmenorrhea. So when come to the prevalence part, so in globally when we see the research studies performed on different population, its prevalence widely varies between 16 to 93%. As well as it also depends upon the ethnic, biological, and social cultural background from different countries. When we talk about UK, the specific incidence of dysmenorrhea in this country ranges between 45 to 72% among all reproductive age women. But this figure can also be as high as 93% in adolescent girls. So the dysmenorrhea frequency also decreases with advancing age, and it is more common in unmarried as compared to married women. According to the International Association of Study of Pain, in 2007, it is reported that approximately 10 to 15% of women were not able to work for at least 1 to 3 days. So according to this study in this survey in 2007, if we suspect up to 2021, the percentage must be increased because there is a decrease in like lifestyle also changes, dietary habits of young women also changes. That's why there might be increase in the percentage also. Therefore, dysmenorrhea is considered as the commonest cause of economic deprivation and loss of working hours in many countries. So next we are going to talk about the causative factor, what can be the causative factors for dysmenorrhea. First of all, there is a uterine contraction. So why uterine contraction and vasoconstriction occur in uterus? Because there is a increased synthesis of prostaglandins. Prostaglandins acts like hormone in our uterus, and during the menstruation there is an increased secretion of prostaglandins from endometrial cells, as well as two hormones that are vasopressin and oxytocin. Their level also get increased, and they further enhance the prostaglandin secretion. So these all things ultimately cause the stimulation of pain carrying C fibers, which causes the pain at the level of the spinal cord, and ultimately it get transmitted up to the central nervous system. So next, move upon this, what can be the signs and symptoms of dysmenorrhea. It is usually characterized by pain in lower abdomen, and that pain may also refer to thighs and low back. So why it refers to thighs and low back? Because as sympathetic fibers travel from uterus to the lower back and from cervix to the thighs level. So these regions, the pain is associated with lower abdomen and thighs and low back. The pain sensations is usually cramping and dull, constant ache, which may be more severe during the first or second day of menstrual cycle. Apart from pain sensation, other associated symptoms related to dysmenorrhea can be headache, vomiting, nausea, diarrhea, tiredness, dizziness, and these all factors further ultimately causes school or work absenteeism and affects their overall quality of life. Next are the pathophysiological mechanisms which are responsible for primary dysmenorrhea. So it only depends upon the two contributing factors, which I already said, it are the uterine contraction and pain fiber stimulation. So in a study of 2013, they demonstrated this thing, that uterine contraction occurs due to raised prostaglandin levels. As I said, it starts accumulating in endometrium lining, and when endometrium lining starts shedding during the start of menstruation, there is a large amount of prostaglandins get released, resulting in excessive uterine contractions, vasoconstriction, and this vasopressin and oxytocin effect further enhance the vasoconstriction and hypoxia in the uterus region. So these all factors further causes the stimulation of the pain fibers, which get transmitted up to the central nervous system and produce a pain sensation. So next we are going to talk about the risk factors related to dysmenorrhea. So previous family history may also be responsible for this condition. High level sports activities, those who play sports activities during this period, frequent meal skipping can be the reason, sedentary lifestyle, short sleeping hours, cigarette smoking, and stress. These are the risk factors of the dysmenorrhea. Now further move on the methods of treatment for dysmenorrhea. Although there are like pain medications have been suggested by previous studies that are the non-steroidal anti-inflammatory drugs, but there are several side effects to these drugs, and moreover some females do not wish to use these medications. And according to the guidelines of Food and Drug Administration, these pain medications can also increase the risk of heart attack, stroke, stomach ulcers, bleeding, especially when it is used over a long period of time. And moreover, mild to moderate side effects of these pain medications can be stomach pain, diarrhea, constipation, dizziness, nausea, and vomiting. So if we other than pharmacological approaches, as there are many side effects to pharmacological treatments, Other alternate approach can be physiotherapeutic approach, in that the various physiotherapist treatment can be used for the management of dysmenorrhea. Among them, other are the superficial pain modalities. These are the superficial hot packs, deep pain modalities, in that microwave diathermy can be used. Other recent treatments like dry needling, kinesiotaping is also being used in some studies for the management of dysmenorrhea. Other long-term treatment, like which can be used for long-term basis, like yoga and exercise, these are also successful for dysmenorrhea. But the transcutaneous electrical nerve stimulation therapy, this shows this shows the instant effects. This is more effective and shows immediate relief as compared to other physiotherapeutic approaches. So now we are going to talk about the TENS therapy. The Stents is a device which involves the application of electrical stimulation to the skin, and it produces monophasic or biphasic pulses in a repetitive manner. So it is a non-invasive device and efficient pain relief method without any significant side effects. So parameter of TENS are the pulse width varied between 50 to 300 microsecond. Frequency can be in the range of 2 Hz to 600 Hz. Intensity, it can be the range of 1 to 60 milliampere. So if we elaborate type of TENS in a more elaborated way, we say there are 5 types of TENS, but first 2 type of TENS, high TENS and low TENS, that are more commonly used in our previous studies as compared to these other 3 types. So this many studies have already proved that high frequency TENS is more effective as compared to low frequency TENS for treating the dysmenorrhea cases, because high frequency TENS is used in acute and superficial pain, so it produces the instant and immediate effects. But low TENS can be used in chronic or weak pain, so its effects are not that instant. But in case of third type, that is brief intense TENS, this is long. In this, there is a long duration impulses, and this can also be used for localized pain relief. Other fourth type is burst TENS. It interrupts a series of pulses, repeated pulses, that can be used for chronic pain relief. Fifth type is modulated TENS. This is very rarely used for the cyclical pattern and help to reduce nerve adaptation, and it can be used for acute pain relief. Next, I'm going to talk about TENS pain relief mechanism. So it depends upon the pain gate theory. So what it says, ultimately, when there is a uterine contractions and vasoconstriction occur, there is a pain stimulation by the small diameter pain carrying fibers. At that time, pain gate is opened. So when pain gate is open, patient feel pains. But when we applied the TENS stimulates the large diameter A beta fibers. So TENS inhibit pain carrying fibers input at spinal cord level, and at that time pain gate is closed, which prevent the pain transmission up to the brain level, and now the patient does not feel pain. So this was the pain gate theory. Another theory is about the endorphin-mediated pain relief method, in that pain is suppressed by the natural pain-killing chemicals, that is endorphins, which are released by neurons. So TENS stimulates endorphins and it increases release, causes analgesia effects. So as there are many TENS devices which have been used for the management of dysmenorrhea. So among them, this Unicare is a new device from TENScare Limited. It offers immediate and effective drug-free pain relief from primary as well as secondary dysmenorrhea, although it has 5 preset programs. But now here we are talking about just the dysmenorrhea periods pain, in that it is this period pain program is of utmost importance. So these are the Unicare preset parameters for the menstrual pain. So these parameters have been observed from the previous studies, and their frequency, their parameters are set according to that. Here frequency can be average can be keep average between on the range of 110 pulse width at 100, and here ramp up and down can be keep at constant level, duration up to 20 to 30 minutes as suggested by previous studies. So electrode placement in case of Unicare can be over the T10 to T12 nerve roots because they supply the sensory fibers to the uterus, and duration we can keep up to 30 minutes. Here electrode placement can be at 3 positions: low back, front in vertical format, and front in diagonal format. So here is the electrode placement in case of Unicare. In low back position, the electrodes can be placed on either side of the spine, and the distance between the electrodes should be 4 inches apart. And when we place it on the front side in the vertical format, the electrode should be adjacent to the umbilical cord and again 4 inches apart. And in the diagonal format, when we place it, should be at the vicinity of the groin area, and we place in the V-shaped, narrowing up to the space of 4 inches apart should be there. So the next are the applications of TENS. These causes the physiological effects on the body. So it reduces the uterine muscle contraction and ischemia, and causes vasodilatation in blood vessel, and this vasodilatation further increases the blood flow and decreases the pain level. Now I'm going to talk about the previous literature and some previous research articles related to the management of dysmenorrhea. So here I'm going to share my own experience, my PhD study on the topic which I have studied among the adolescent girls. I've seen the efficacy of high frequency TENS on adolescent girls. The aims of my study were to evaluate the effect of TENS at dermatome level, that is at the lower abdomen level, to evaluate the effect of high frequency TENS at root level, that is at low back region, and to compare the effect of high frequency TENS at dermatome and root level. So the study design was I had taken 210 adolescent girls between the age of 14 to 19 years of age, and then I randomly allocated them into 3 groups. The A group was the high frequency TENS dermatome level group, second high frequency TENS root level group, and third was the control group. And first group, that is A group, I have placed high frequency TENS electrodes at the lower abdomen level, and in group B the electrodes were placed at the low back region at the root level, and in third group, control group, no intervention was given. So measurement, what I did, the measurement at 3 sites I have performed, that lower abdominal pain at the lower abdomen level, low back pain level, and thigh region. So these 3 level measurement was performed by an American Pain Rating Scale, that is NPRS scale. And then I measured the blood pressure also by the aneroid sphygmomanometer. So when the patient came to me on the first day of the menstruation, I first assessed her current age, because I kept the inclusion criteria according to the setting of inclusion and exclusion criteria. I assessed the age at menarche, the body mass index of the subject, then the location of the pain, that the pain is at the lower back level, should be there at the lower back level, lower abdomen level, and at thighs level. And then I assess the severity of menstrual pain according to NPRS scale. So this was the inclusion criteria for my study: 14 to 19 years age group, regular menstrual cycle, experiencing self-reporting pain for continuously 3 consecutive menstrual cycles, and pain should be moderate between 4 to 10 on numerical pain rating scale, and the adolescent girls should be with no gynecological pathology, and pain must be at all 3 sites, and their body mass index should be in the normal range. So exclusion criteria, I excluded the subjects with secondary dysmenorrhea and the with mild to infrequent dysmenorrhea, and those who are using any kind of drugs, and those who are unwilling to give written consent, and those are diagnosed with any chronic disease or any psychiatric illness. I excluded these subjects from my study. So I had taken the written informed consent, and the subjects were randomized into 3 groups. And before randomization, I did the pre-assessment, with the numerical pain rating scale and blood pressure by sphygmomanometer. So these were the 3 groups. And then after the intervention, again I did the post-intervention assessment, and the data was collected and analyzed. So this was my intervention in group A subjects. The position, this was the position of the subject, and the electrode placement were 2 electrodes were placed at umbilicus level and 2 electrodes at the inferior superior iliac spine level. So the parameters of high frequency TENS were as shown. The parameters was similar in group B also. Only the placement was changed. Here the placement of electrodes at the low back level. So 2 electrodes at the proximal margin of low back area and 2 electrodes at the gluteal region. So again here parameters are same of high frequency TENS. So in group C, I had not given any intervention. I just make the subject to be in a comfortable position. So the subject is in prone lying with a thin pillow placed on the under the lower abdomen to attain the comfortable position. And again, the duration was same as of group A and B of 20 minutes. So what was my study findings? That reported that although both TENS at dermatome level, at root level shown significant improvement, however, there was overall more significant improvement in group A as compared to group B and C. Thus, the finding of the study indicated that TENS is a safe, effective, and one of the best non-pharmacological method in managing primary dysmenorrhea. So, strength of my study was that many studies were postulated the effect of high frequency TENS dermatome level and high frequency TENS at root level individually. But there is limited evidence on the comparative effect of same parameter on 2 different levels. Thus, the present study investigated the comparative effect. And the cost effectiveness of my study is that the participants gained a potential benefit study that leads to improving the loss of their working hours and their overall quality of life. Moreover, treatment through TENS was relatively inexpensive, easily accessible, and without any side effects. So in my study, I want to add in my studies, I use the machine like StimTech 4 I use that was almost similar with the Unicare device. So next study I'm going to share, this is a more recently published study in 2021 study. Actually, they just published the study protocol. The results are still awaited. They have not declared the results yet. So study protocol they have shared. The aim of the study was to evaluate the effectiveness and cost effectiveness of TENS in women with dysmenorrhea. They have taken 174 women more than 18 years of age, randomized into 3 groups, and the participants allocated into active TENS group, placebo TENS group, and educational booklet group. Here the study hypothesized that they have hypothesis about the study because the results are awaited. They hypothesized that active TENS will be more effective than placebo TENS or the educational booklet in improving clinical outcomes in the short, medium, and long term. So why I included this study? Because the good thing is that they have evaluated the economic assessment of the participants. That will be done from the healthcare and societal perspective, and all they have just calculated all costs related to menstrual pain, like cost of intervention, healthcare, and cost of over-the-counter pain medications. And they have used one scale that is Brazil validated version of Stanford presentism scale, which will be used to measure presentism, absenteeism from paid work, and the estimated price of productivity loss on per absent date among women. So there will be many potential impact of these studies that are, it is not very common for every woman to seek help due to this dysmenorrhea pain, because this dysmenorrhea is not considered as a legitimate health issue. So this, I should say that there should be an increased attention among the healthcare providers, society, and women to start looking this dysmenorrhea as a health issue, and this can be easily treated with other non-pharmacological interventions also. So as Stents has proven efficient effect for the treatment of dysmenorrhea in previous studies, therefore, it is suggested that healthcare professionals should recommend the use of Stents and should start assisting women during this period by their evidence-based practice. Moreover, Stents is cost-effective and it should gain more possibilities and attention among healthcare professionals, and if the symptoms of dysmenorrhea can be improved with Stents, then it can indicate the economic impact of the disease. It may reduce the decreasing absenteeism and also reduce the use of medications. So this was the another study, systematic review and meta-analysis, which was published in 2020, and the purpose of this meta-analysis was to determine the effectiveness of Stents in the reduction of pain in primary dysmenorrhea. So they have found 571 records and 4 studies meeting the final inclusion criteria in the review. And out of 4, 3 were the randomized control trial and 1 study was crossover control trial. So according to Pedro scale, this Pedro scale is being used in systematic and meta-analysis reviews to assess the methodological qualities of various experimental studies. So here they assess the methodological quality. Out of 4 studies, 1 study was fair and 1 was good and 3 was excellent. So in this, they have 260 participants were enrolled in this all included studies, and high frequency Stents were used in all studies. Frequency was in the range of 0 to 120 Hertz and duration between 20 to 30 minutes, and comparison intervention was sham Stents. So 3 studies among 4 studies have shown no adverse effect of Stents, while 4 studies did not provide any information regarding adverse effects. So this was the forest plot of this meta-analysis, which indicate that Stents was statistically more effective than sham treatment in reducing primary dysmenorrhea related pain. So therefore, Stents is a safe, well-tolerated electrotherapy device for relieving the pain in dysmenorrhea. So future research indicates that, I should say, that there should be a combination of Stents and more long-term interventions such as exercises and yoga to analyze the cost effectiveness of the combination of these techniques. So here I complete with my presentation. Thank you.
So I was a bit late unmuting myself. Dr. Manisha, very, very big thank you for that beautiful presentation. I'm sure quite a lot of people have found out something interesting for them and learned something new as well. It was really good the way you actually covered different publications, including yours. I was wondering whether you would do that or not, but thank you, you've done it. Whilst everyone is still muted, I'll probably take about one minute just to unmute everyone so people can ask some questions. I don't know, Professor Richard, if you have any questions or any comments on that whilst I'm sort of letting everyone sort of to speak. And we also have a question in the Q&A box that is a really valid point. I know my colleague Madeline wants to comment on that, so maybe I'll just unmute her first, and then we can discuss any other questions. I just need to find. Go on, Maddie.
Okay, so the point that was raised with us, which is very valid, is that it's not only women who live with endometriosis, it also affects non-binary, genderqueer, and trans men. And I think that is a very important stat and figure that we need to acknowledge, that many people suffer from this condition regardless of how they view themselves. So thank you for that and raising that point with us. This device will be able to assist any sufferers of the condition and be able to relieve the symptoms of any sufferer. I don't know if any of our doctors or Lisa has any further comments on that.
I actually wanted to ask a question that bothered me for quite some time, and I've actually discussed that with my colleague Andrew Brown, who's our quality and assurance manager. Oh, sorry, it's a bit noisy. Can anyone just mute themselves while they have some noise? I'm not sure who. I think I don't know what to do, guys. Can you mute yourself, please, because there's quite a strong background noise coming from someone. Yeah, found it. Good. Dr. Manisha, maybe the question would be addressed mostly to you and Professor Richard as well. Is obviously we in our product we have 4 electrodes, and I know there are other products on the market that actually also offer 2 electrode placement. But how about placing the electrodes on both the lower back and the front? Will that be more effective, or it's not going to make any difference to the treatment? What is the best recommendation on that?
Actually, it does not matter 2 electrodes or 4 electrodes. If the size of the electrode is large, then it can cover the large area also. So the effects were similar in case of 2 electrodes and 4 electrodes. Moreover, the electrodes placement can be individually at the abdomen level and at the low back level. We can't simultaneously place the electrodes at the low back level and anterior abdominal level. And my study also concluded this thing that when the placement of electrode at the abdominal level, that will be more positive effects as compared to back when we placed at the back region.
Yeah, yes, I agree. It depends on the size of the electrode. If you have large electrodes, you can use 1 channel. And I would like to ask a question to Dr. Manisha. First, yes. Congratulations for a very nice presentation and for your article recently published. It's a very good study. And you used 4 electrodes, so 2 channels. I would like to where did you place it, each channel? It was 1 channel and one side of spine and another channel in another side, or did you cross the channels?
No, I have not crossed the channels. I have placed the channels adjacent way. On the front side, one pair of electrodes at the level of umbilical cord, and second pair of electrodes at the level of anterior superior iliac spine level. So I placed the electrodes adjacently.
Thank you.
I just maybe need to mention that Professor Richard actually is the author of a paper that's of the work that's called Effects of Thermotherapy and Transcutaneous Electrical Neurostimulation on Patients with Primary Dysmenorrhea. So it was also a randomized placebo-controlled clinical trial. If I'm correct me if I'm wrong, Professor Richard. So you also lecturing at a university, if I'm not mistaken, or is that not accurate information?
It's correct.
Correct. Good. Does anyone from our guests have any questions or tenskating? I know quite a few of you here. Anyone, any questions? No? I think it's a bit silent right now. I think people might be feeling. Andrew?
No.
Yes, there is a question in our Q&A box, and it comes from an anonymous attendee. So is Stents better than using a warm bottle, and if yes, why?
Yes, of course, Stents is better as compared to warm bottle, because warm bottle is just a superficial heating modality, and this Stents stimulates activity at the brain level. Here I discussed the gate channel, painway gate channel. It get closed at the level of central nervous system. So this is actually more effective as compared to warm bottle.
Yes, I would like to point out that either high-frequency stents or conventional stents and low-frequency stents or acupuncture stents activates opioid receptors in the central nervous system. The high-frequency activates delta opioid receptors, and low-frequency stents activates mu opioid receptors. So we have a very interesting effect in the central nervous system. And so this is the reason that TENS application is much better than superficial heat for dysmenorrhea.
Yes. Right.
Can I just ask a question about duration? The clinical trials are all talking about 20 to 30 minutes. But if you're talking about high frequency TENS, the effect wears off very fast after you finish using it. So we've recommended that you would use a high frequency TENS for as long as it gives pain relief, for 2 or 3 hours. I don't think, I just wondered what you think about that.
So, as the previous research suggests, that it has like instant effects. So it can generate effects in 20 minutes also. So that's why the studies have taken 20 minutes, because they have to take the large amount of data on different subjects. To cover up that data, they have taken just 20 to 30 minutes, because this can also create the positive effects on the individuals.
Okay, thanks.
In my opinion, you can use a little bit longer. The only caution we need to have, some textbooks recommend using the maximum 1 hour and give a break, because some patients, they have some skin irritation. So you can do this, but you can use more time. I don't see this as a problem. Okay, it is very common, like 40 minutes, 1 hour application. If you apply TENS for more, you have a longer post effect. So the analgesia takes longer. Okay.
Okay, thanks.
So here, one more thing that I would like to add: if we like apply the TENS for longer duration, it will generate the adaptive effects. There will be adaptive effects of currents, and after some time, patient may not feel that much current that we feel in the initial time period.
Okay, yeah.
Good. Any more questions? I think I've unmuted almost everyone. No? I guess we will just take a break then for now, and then there will be another Q&A session at the end of the second part of the presentation. I just wanted to say once again, thank you very much, Dr. Manisha, for your time and for sharing your experience and knowledge on this subject. And obviously for your time, Professor Richard, as well. I know you have to go. You have another event to attend at 12 o'clock. So thank you very much for being with us. And thank you, Madeline, for giving us that intro on data. As you all have heard, it's a really, really big problem around the world. It's not very well spoken. So hopefully we will add to the improvement of that. And together, I think it's better to be together than just not to talk about that. So for now, we have a 5-minute break. So if anyone fancies any drink, this is the time. And we will prepare for the second half of the presentation. So it'll be our product information, product training, product launch presented by Amna Shahzad, and some design specifications that we've considered when we were developing this new product. So will be presented by Han Wei, and another Q&A session at the end. So stay with us. We will start in 5 minutes. Thank you very much, Dr. Manisha and Dr. Professor Richard.
Thank you very much.
I'm now to just share your